Okay, so our next speaker is a radiologist specialising in women's imaging, based at the Texas Health Science Center in Houston, Texas. Dr. Bodne brings extensive clinical expertise in women's imaging and is dedicated to improving early detection methods in breast cancer. So please put your hands together for Dr. David Bodne.
It's going to be too hard to actually follow there. Hopefully y'all can hear me okay. So basically, it's going to be too hard to actually follow. Like I said, David and Roger both sort of presented most of what I'm going to talk about, but I get to play with the toys that they basically have developed. So I'm going to basically give you some of my experiences more than anything. I'm also, I don't know if any of y'all follow me on LinkedIn, which I've learned is a good social media site. What I tend to do on LinkedIn is basically put in anonymized cases. These are just real cases that I have seen as I'm reading these studies. So basically, I have been with Texas, although now sort of on my own, getting a chance to read some of these. Let's see if I can figure this one out. So this is essentially for the radiologist. This is really for everybody that basically experiences. This is a patient going through, I don't know, was this a video?
Yes.
Okay, so I can get this to work here. This is basically a patient, there we go, patient experience, what it's actually like. They can get up, the ladies like it because they pretty much are not manipulated. I've had some friends that are mammography techs who I think we're going to put them out of business. Hopefully that's not the case, but basically, you know, a lot of times with the mammo techs, what they'll do is they're going to be positioning the breast and manipulating, positioning the breast. This one is basically the lady lays down and it's positioned pretty much the same from year to year, which is nice because a lot of times we'll tell these ladies when they come back and, you know, follow up year, for instance, we might have a finding that may not be a real finding, but it's there because they're positioned differently. And so then we have to bring them back for a diagnostic exam to tell them it was just a summation artifact. So that's one of the nice things about this. I usually describe this as basically, rather than a human being positioning, this is God and gravity usually positioning you. So it's pretty much the same from study to study. The nice thing also about this is for callbacks, which we'll get into, usually my reports, how do we get the volume up on that?
Insecurity, as opposed to having a traditional mammogram, it was much, much more comfortable.
And that's a pretty common theme that we get as well. Ladies like it. You know, when we tell them, and I will tell you, my experience has been, this is at least as accurate and as good as FFDM and DVT. The nice thing about it is because it's 3D, it actually helps me feel more confident in callbacks as well as when I'm calling negative. But the ladies like it. Their big concern, their big question I always ask is, okay, where can I get it and does insurance cover it? So the last question we'll answer at some point, hopefully sooner rather than later, but that has been their big question, but they love it. So ladies are asking for this. We actually had a lady, we can get back here real quick, we had a lady, so the center that you've seen images of is in Tifton, Georgia, which is a small city in the center of the state. We've had ladies travel there from Canada, from Texas, from Florida to just get these scans. So there's a lot of interest. So this is what I was talking about with regards to triangulation, because you're dealing with basically 3D data. I can triangulate, and if I have a finding in one view, for instance, I'll scroll through the other views to see, because you can triangulate exactly where it is. I can tell, is that a real finding? Is it a one view only finding? Is it glandular tissue that looks like it's localized in one view? The other nice thing that you can do, like you do for CT, is measure attenuation. And usually glandular tissues won't have comparable attenuation to glandular tissue. And so we had a case where actually it caught my eye. It was a little bit denser, put an attenuation cursor over it. It was higher by about 30 or 40 HUs. We brought her back. So that's basically how I use the triangulation, both to help me find things, localize things, because also with regard to localization is in a report I'll put on there, for instance, if there's a finding, I'll say this is best seen on coronal slice 230, for instance. And what will happen is when the patient comes back, instead of guessing, because a lot of times if you've had experience in a diagnostic center, especially busy, they'll come in, they do the study, well, is that the right one, is that the same one, you don't really know, you've got to go through, you re-radiate them, reposition them, the whole thing. The other thing is with regards to compression on dense breast tissue, and you know, a lot of the ladies will say, well, I get compressed because I care. Well, that's great, that's fantastic, it's very helpful. But I also say, you know, sometimes the breast tissue is so dense, it's like compressing cream cheese. You're not going to see Doesn't matter how much compression you have. That's not been an issue with this. So I can find the finding when they come back for the diagnostic right away. Also the ones that are negative, if I've got a question, I can tell you they're negative because they're not real in previews and because of the same attenuation. So these are some show and tell cases. This is a lady that had a mass, you can see on the mammogram, mucinous carcinoma, and you can see the same findings. So, you know, somebody asked, when you started reading these, what did you use to help to learn to read these? Well, I mean, if you've read mammograms for, you know, several years, there's nothing new. There's really nothing new under the sun. You are seeing more, but the findings are the same. So, you know, it really doesn't take that much longer to read once you get up to speed, but it's the same finding. Okay, so you see it a bit better, but that's basically what a study looks like, and you see the 3D as well. Again, with attenuation measurements, it's nice. We're looking at different things. I think it's going to take a little bit of study, but are there certain attenuations that are significant? I mean, what I've used is basically if it's 30 or more HU above glandular tissue, they're going to come back. They're probably going to get a contrast study just to get a better idea what's going on. We had a lady that had a B density breast that would never have gotten any other studies, and she had a 1 centimeter cancer that showed up that way because the attenuation was a little bit greater. She came in and you could see the enhancing mass. So this is one nice feature. You can actually see, you know, and I think it's going to take some study, is are there attenuations that may be more relevant, but show you cysts or fibroadenomas. It's going to take some time, but at least that is something that's available that's nice for the CT. Let's see, there we go, this is another video, okay. Pardon my recorded nasally voice there, I think this is me. The way I read these is essentially starting with a thicker section. Usually I go with the 10 millimeter, and that's essentially gives you a view that's comparable to the synthetic view on tomosynthesis. And what you're looking for with these is essentially looking for calcification, just get a sense of where they are, what they look like. You look at distribution, you see subtle, I mean not subtle, but you can see a benign apparent calcifications for about 5 position there on the breast. We're looking at the left breast here, so nothing else. And that's really more of an overview, like looking at the synthetic views. And what I can do is I dial it back. These are 0.2 millimeter thick sections, and this is where I do the meat of my work. And so basically what I was looking at on this particular lady was there's an area that just caught my eyes, very dense breast tissue, but right up in this area, it just looked a little bit more dense than other areas of tissue. I did some measurements. One of the nice things you can do is you measure attenuation, and it just came out a little bit denser. You can see compared to background, looking at maybe 109, 110 compared to other areas, it's maybe 50 to 70. So just it stood out to me. And triangulation, you see it's really just dense breast tissue. So we called her back for contrast, and on the contrast study, what you can see is this area in the same region that enhanced that other area, but this area that we saw, basically you can see it enhanced. It is now coming in about 180 compared to the 110, so it's significantly enhanced. The background tissue, of course, you're also going to see some enhancement, but not nearly as enough. Not really the same. I mean, it's a little bit, but not as significant as this area, which could have been biopsied if they had the device to be able to biopsy. At this facility, unfortunately, they did not, so the lady went for an excisional biopsy with the surgeon, and this turned out to be invasive ductal carcinoma. You can see how nicely you can triangulate. You can pretty much describe the size, enhancement. You can give a position. I usually give the position on a coronal so you can target it or come back to it easily for reference for follow-up and distance intervals. You give the usual measurements as well. So that was the case I was talking about that went on to be excised. Let's see. This is the same case. This is an interesting case. So this shows basically on the digital mammogram, we've got one lesion that was of concern. She came in for the study that's not popping up. Is this a video? Oh, good, okay. Wait, okay. Pardon this, we had a few changes on that, so it's just one is coming up. Okay, so just go through it. Basically, you see the lesion in question, but then there were some other lesions that we found as well. So we are finding a bit more on the CT, so we've got a few other lesions that showed up that became significant. That was different, it wasn't quite a video, okay. Then there's the issue of contrast. So contrast, what we're finding, I don't have a lot of experience with contrast mammo. But, and I've raised this, and anybody that wants to connect on LinkedIn, we're also looking at starting a online tumor conference as more of this comes out. And basically, with contrast enhancement, everything about it is pretty much the same as giving contrast for contrast mammo or for an MRI. So it's the same pharmacokinetics, the same physiology that you're seeing. The nice thing about this is, though, is that you can target biopsies. And so I've done several biopsies. It's a lot like an MR biopsy, where if you've got multiple sites, you basically go in with a coaxial system and you localize everything you need to do. I've done 3 in one breast. You go through localized 3, you can pretty much do 3-site biopsy in 10 to 15 minutes. I don't know if that's going to be comparable with contrast mammo, plus it's radiated at just the one time. So, you go in and do the biopsy essentially exactly like an MR biopsy. A little more show and tell. I don't know if these show up so well. You can see some calcifications that we saw on the mammogram, and then you've got on the MR, you've got some non-mass enhancement, but you don't see the calc. So really, the nice thing about CT is that you're putting everything together. So you've got the calcifications and you've got the mass that you can see. One of the questions that we were asked, which I don't know the literature offhand, but can you see vascularity in these lesions? And I've seen this several times as well, where you can see vessels actually coming to the mass. So you can see it. The resolution is there to see that. Okay. Same case, you just get a sense of what it is in 3D. I think this is going to be helpful for our breast surgeons to get a sense of exactly what you're going after, what's the best approach on the 3D part. I don't routinely use the 3D for reading, but it is helpful. Run through that one. This was a paper that came out actually recently I thought was interesting, and that is, kind of leads into some of the discussion I'm going to bring up, and that is, can you use contrast mammo to replace MR for extended disease evaluation? And the gist of this paper is that they think you can. So if that's true for contrast mammo, would it be true also for CT? Real quick, some of the procedures I've done, pretty much all of these. We also placed a mask, because the mask was very close to an implant. We didn't have enough space to create the vacuum, so we basically just put a marker in there. But you can do pretty much anything that you need to do, that you can do with MR, you can do with this. This is pretty much what the procedure looks like. Is this another video? No, it's not. Okay. But basically, there we go. That's this video. The lady is in the same position. The thing also about this compared to MR biopsies is you can easily do both lateral and medial approaches. So you're not going through the tunnel that you do, when you go through for an MR biopsy. So it is comparable to that, and pretty much everything is about the same. You're going through, you do the targeting on the console. It gives you the depth. It gives you the X, Y, and Z axis on the grid. It's a very nice system that's designed. This is what an actual biopsy, what we see. You can pretty much get a sense of where things are. Everything else is the same as a regular biopsy. So from some future possibilities, so I'm no longer hospital-based, so I'm not doing these, but you can do them. It's the same localizations. You can put in seeds that you can't put in with MRI. You can put in the radioactive seeds, but there's probably 10 different types of or wireless localizations. You can do those. This one is an interesting, and I'll bring this up in a second. And the other thing, I'm talking to a company, I think it's IceCure, with regards to cryotherapy, and their thoughts are the same, and that is because you're in a prone position, you can remove the lesion further from the skin, which is the concern with cryotherapy. So just things that are at least being discussed. And then for hybrid imaging, so there is a paper, and I can't get that one in here. There's a paper a few years back. Basically, one of our difficult lesions to find is invasive lobular carcinoma. I've talked to some big name radiologists, and this is one that we commonly miss, and it's because it's just the way it grows. They're very subtle signs, and one of the papers that came out suggested that symptom mammography BSGI actually might be more sensitive in detecting this. The reason, at least from my experience, that this or PET mammography really hasn't taken off is because you can't localize the findings. So if you find something, we really don't care, say that the lady needs a mastectomy. So this is possibly, if we develop hybrid imaging, which we're talking about as well, you can localize and biopsy spots that you also find. So this may be helpful to sort of combine the best of both worlds. There it is. Sorry, the paper did come out. Okay. Well, that's basically, this is what it's showing, so that BSGI is actually better than mammo MR for finding invasive lobular carcinoma, which is a tough one. Like we said, basically one of the things we talked with CAD companies, you know, that case that I found with the attenuation changes, it took a little bit of time. It took a little bit of time, but I think with CAD or with AI, I think that's going to help the reading time as well and cut that down. Am I getting close? Am I good? Yeah. Sort of? Okay. Yeah, hopefully, so the thing that I'm looking at, so, you know, one of the things we talk about is finding smaller cancers. And this is where I think, if that's all we're measuring, I think we're going to be comparable to mammography, to FFDM. I think you can find a 5mm cancer at both, you can find a 4mm cancer, so you're going to find when they're treatable. The question is, can you go from that first screening to the first treatment? Which is, to me, I don't know if anybody measures that time, but that to me is something significant. Having had a relative with cancer, you don't want them waiting around for a prolonged period of time going through the workup. So that was one of the thoughts. Contrast enhanced, one of the things you look at, you know, we talked about dense tissue screening. I think breast tissue density and attenuation we're seeing on CT are comparable. So I think we might be able to use CAD or AI to help us with that as well to determine which ladies are truly dense. I had a case I just put on LinkedIn the other day. It came out on an outside study that was measured as a C density. It was maybe an A, it was pushing to make it a B. So I don't know how accurate our measurements are currently when we talk about breast tissue density, so this might help us make it more reproducible, make it more accurate. High-risk clinics, one of the things we talk about, and I don't know in the UK and the States, one of the things we find, we talk about is ladies that are BRCA positive or at high risk, and when you get screening, these are usually younger ladies, and the reason these clinics have a hard time is because pretty much the recommendation is to add MRI to screening. Well, the ladies will show up, the insurance doesn't cover it, it's $4,000 out of pocket, they walk away, they're done with the clinic. The cost for this, I think, is going to be quite a bit less than an MRI. I'm told on the order maybe a few $100s as a few $1,000s. So I think that might help some of these high-risk clinics actually take off. The implants, as Roger said, basically you can see those. This was a case that we had. You can see pretty much, and this is standard, so you're not doing any extra studies. It's on a screening test. We see this, we report this. I'll routinely report, you know, the subpectoral implants are intact, or if there's a subcapsular rupture, things of that nature. But this is on a regular screening test. No additional MRI is required. They go straight to this. So you're going to save the cost, obviously, over time of having to do that extra study. I think the plastic surgeons are going to like this because I'm told their literature is suggesting that you need to evaluate these every 2 years or so. So this is going to be a nice way that you can add that screening. Currently, you know, we're talking about different things being offered for dense breast, ABIS, which is what the literature supports. I don't know many places that do that. Handheld is great if you have the staffing for it. You know, with regards to radiologists and dedicated breast sonographers, they're limited. They're just a limited resource. So the question is, how often is that done? I don't have an answer for you, but I'm not seeing it in the States. We're not seeing it a lot. Now I'm talking about MRI. So MRI is a great test, but the problem is going to be, I can tell you as a practicing radiologist, we walk in to our day, and our big question we have, what is the day going to be like? How many MRIs do we have? So if you're going to bump your MR count by 50%, I mean, that's something that we've got to consider when we're looking at our limited manpower for radiologists. And so one of the answers that came out of, I think, out of Germany was, we can do the abbreviated scale. If you're going to bump it 50%, but you can do the abbreviated, and you're going to bump it 70%, I don't know if that's necessarily answering the question. And the other issue, of course, is MR availability. I don't know how available they are. I know in the States, probably more so, but still, you're going to tie that machine up doing another 50% for that. So the bottom line is this, and when we started this was the phrase that came up is standard of care. And so, you know, I started to look at that. Standard of care is a legal term, it's not a medical term. And so really what we do as radiologists, I kind of liken us to the drivers of the car, that we find the diagnosis and then we drive the car and we have, you know, great time, we did a fantastic job. But how long is it going to help, how long does it take for us to get that patient then to the point of treatment? The standard of care is really defined by when they start getting treatment. And so that's really the question is, can we as radiologists help get them to that point, from the point of screening to the point that they get their first treatment? So experience so far for radiologists, I mean, it's a learning curve. There's always a learning curve for everything we do. But once you get up to that flat point of the curve, it's really about the same amount of time as for DVT. Biopsies are comparable, like I said, for MR for multiple sites. The key thing is going to be on the bottom ones. The question is, are we going to find earlier cancers? Possibly, but one of the sites that we tested, the compliance went from 30 to 70%. So we may not be finding necessarily smaller, but we are going to be finding more of them just based on the numbers. So I think compliance is going to be a critical issue. If we can get them into screening, we can find them. If they're not going to come in, it doesn't matter. I guess we'll save that to the last part. Okay, let's skip that slide. So this, I kind of came up with this, and somebody asked me, and we were trying to do an animated part of this, but in a perfect world, if I could be given, you know, David, you can have whatever you want, let's set up the perfect center. So I think, for me, and we're looking at some of the protocols, they come in, they get their screening exam, that's stage one. The next one, they're coming back for diagnostic, but instead of just working up the one finding, let's work them up as you do an extent of disease, because what you're looking for is basically what needs to be biopsied. So the extent of disease, what we've tested out is the ipsilateral breast to 2 points, you can get a measurement of an enhancement curve, maybe a washout curve. Then you do the contralateral breast on the same setting, and you do bilateral axillary ultrasound. So now you know after that workup exactly what needs to be biopsied. So then you go in, you bring them back for the next, and you do the biopsy of everything that needs to be biopsied. So now you have an answer. One of the centers I used to work at, they actually, once the lady was diagnosed, they set up a visit with the breast surgeon, the medical oncologist, radiation oncologist, and the nurse navigator, one setting. So the question, and really the only rate limiting step in here is the pathologist, how long it takes them to get you back the results. But it's feasible if we've got a pathologist that can get you these results back in a week, that you might be able to go from screening to the first treatment in a month. That would be a nice thing to do. In a perfect world. So the bottom line, I think this is the critical take-home point for what I'm trying to get and what I think the benefit of CT is going to be. And that is, yes, we can find it early, but I think as we work out the details, I think we can also treat it early. Thank you, everybody.